All right. Welcome back, everyone. So we'll now proceed to our next session on lower limb differences. I have the pleasure of introducing our speakers. We'll start with Dr. Sanjeev Sabharwal. He is a pediatric orthopedic surgeon who did his residency in University of British Columbia, followed by a fellowship in pediatric orthopedics at Children's Hospital LA and at the Shriners Hospital for Children. He also completed a second fellowship in limb lengthening and reconstruction at the International Center for Limb Lengthening in Baltimore. At UCSF, he serves as program director of our Pediatric Orthopedic Fellowship and director of the Multidisciplinary Limb Lengthening and Complex Reconstruction Center at Benioff Children's Hospital in Oakland. Dr. Sabharwal will be joined by Dr. Jaclyn Hill. Dr. Hill is also a pediatric orthopedic surgeon. She did her residency at Harvard Combined Orthopedic Residency Program, followed by a fellowship in pediatric orthopedic surgery at Boston Children's Hospital. She recently joined our practice from Texas to develop a practice in lower limb lengthening and reconstruction. Next up is Dr. Yumi Mitsuya. Dr. Mitsuya is a pediatric physiatrist who specializes in pediatric patients with neuromuscular disorders, including spina bifida, neurotrauma, spinal cord injury, cerebral palsy, and spasticity. She completed her pediatric residency at UCSF Benioff Children's Hospital, Oakland, and physical medicine and rehab residency at Stanford. She is part of our multidisciplinary team at the Lower Limb Lengthening and Complex Reconstruction Center and serves as the division chief for Benioff Children's Hospital, Oakland Physiatry. Next, we have on the list is Brent Hisaka. He is a physical therapist who specializes in caring for children who want to start, maintain, or return to an active lifestyle. Brent earned his bachelor's degree in exercise biology at UC Davis. Then he earned his doctor of physical therapy degree at Samuel Merritt University and is a board-certified orthopedic clinical specialist. In addition to treating sports injuries, he is the physical therapy team lead for our Pediatric Limb Lengthening and Complex Reconstruction Center. And last but not the least, we have Alexander Geraldi. Alex is a physician assistant who cares for children and young adults undergoing orthopedic surgeries. Alex earned a master's degree in physician assistant sciences at Loma Linda University. He has expertise in a wide range of musculoskeletal problems, including limb deformities, limb length discrepancies, and complications related to skeletal injuries. So without further ado, I'll pass it on to Dr. Sabharwal.
Thank you, Yumi. And I think some of you were here last year too. So it's kind of a similar format. You've got about 90 minutes to talk and it'll be pretty interactive. We're going to split it into three sort of sections. First, Dr. Hill's going to give you a broad overview of limb differences, what's physiologic, what's not. And then I'll follow with a sort of a little bit more into what are the treatment options. And then we'll open it up to our panelists, and they're going to talk about, how to integrate a team with multidisciplinary expertise. And we'll sort of do the discussion circled around some cases. Okay, so Dr. Hill.
So good morning, everyone. Thanks for inviting me to speak, Selena, and the other co-chairs. You heard that I'm new to the Bay Area, so hope to meet everyone and get to work with you all. Today I'm going to be speaking about torsional and angular development and pathology of the lower extremities. Oh, that does not project well. Looks okay. Hopefully you can see. I have two disclosures that are not relevant. This background is not projecting well. It did not look that, I apologize, did not look that dark. So maybe we'll see how it goes. Okay, so my goals today are to discuss what's normal and developmental and what is pathologic, to review the history and physical exam for rotational and torsional alignment, and examples of what's normal and what is deformity, and review the history and physical exam of angular coronal plane alignment and examples of normal and deformity. Okay, so the first topic that we're going to talk about is torsion in-toeing and out-toeing, so kind of rotational development. So the first thing that I wanted to say about torsional development is that this is really how we are modeled intrauterine, and it's not necessarily pathologic, it's a normal development. So there are a couple of different anatomic regions that we think about torsional development and kind of working from the top to the bottom in our lower extremities. So the femur, intrauterine, there's femoral anaversion of the hip, there's external rotation of the hip, which is soft tissue, internal rotation of the tibia, which is bony, and then there can be variable positioning of the foot, which is usually very flexible. I'm gonna change it to this, I think it will be no different. Okay, and then we start there as babies, and then when we're done growing, our normal adult rotational profile is usually reached by the age of about 10. And we have 15 degrees of tibial external rotation, about 20 or so degrees of femoral anteversion. And so the kind of take home point here is that from birth through 10, there's really a lot of change that's happening, and it's really a moving target to try and diagnose what the exact rotational profile is. And again, starting from the top to the bottom, when we think about what causes internal rotation or in-toeing, in the femurs, it could be femoral anaversion, and we're going to get into each of these topics more in depth, then tibial internal torsion, and then at the feet, metatarsus adductus. So anytime we approach any patient, as I'm sure you all do in your own clinics, we want to take a thorough history that's obviously relevant to the problem that we're talking about, and then also the next step is physical exam. So especially for this, as we know that the development of the legs changes as they grow, we want to know how old they are. And then how long has the problem been present? So did it occur at birth? Is it getting better? Is it staying the same? Is it worsening? And then what are the functional consequences of this? So lots of parents tell us, as I'm sure they tell you, that the kids trip a lot and they think it's really abnormal. There's really no amount of tripping, in my opinion, that's abnormal for a toddler, but obviously as they get older and they develop a more normal gait, then tripping a lot can be abnormal. What you want to know is it both sides or just one side? Both sides less likely to be pathologic, unilateral more likely to be pathologic. And then is there anything abnormal about the birth history, their growth patterns, or family history, as that might tip us off to some kind of etiology? So physical exam, there are two components of physical exam that we look at for this rotational profile. So one is just static. So what do they look like sitting next to their parents? And then the next portion, which is a little bit more relevant for rotation, is dynamic. So overall height and weight, do they have any appearances that look syndromic? We're looking at their spine, their leg lengths, ideally in a standing position, and then what their overall leg alignment is. Apologize. And then dynamic. So this is really important for us when we start seeing a patient walk and trying to put together an overall rotational profile. So looking at the determinants from the femur, tibia, and foot. What does their foot look like? What position it is in what position is it in when they start walking? And we call this the foot progression angle. One thing that is very hard to evaluate is a quote unquote toddler gait. So when they first start walking, they often are very wide based and kind of waddling. And it is much more stable for these kiddos to have their feet turned out. And so they often can look like they're kind of out-toeing a little bit just for stability. And so a normal heel-toe gait is really not established until their age of 3 and not mature until the age of 7. So always kind of use caution when evaluating a child's gait when they first start walking, especially those first few months of walking. The parents are often really concerned, and often it looks different for every child. So they'll say that, you know, the older sibling didn't look this way. Why does the younger one look this way? But they all kind of develop and kind of figure it out differently. And so just kind of to use patience in that evaluation. And then, you know, the foot again, this overall rotational profile, we're looking at the foot progression angle. So which direction is the foot pointing? So if you look at, if you do send a patient to us and then you see our notes, the way that we denotate this is 0 is pointing straight ahead. By convention, turning in is a negative number, turning out is a positive number. So if they turn in like -10, it means that their foot's pointing in 10 degrees. If they turn out, then it's like plus 30 degrees. So just when you see that in the note, that's what minus is in and positive is out. And then we're looking at the position of the knee and gait. So a lot of times, especially the older kiddos, the parents will harp on them to point their feet forward. And so it kind of masks some of what's going on upstream in terms of in the femur. And so you can try and decode some of that by looking at the knee position with the foot forward. And then we're looking at their overall coordination. So this is just hinting at, the foot position is not always what the overall rotation is. So if the feet are, for example, in A, and that one all the way on the left, which projects okay, the feet are turning in, but the knees are forward. So one might think that, okay, if the knees are forward, that might be tibial torsion. Whereas when the feet are forward here, the knees are out, again, maybe tibial torsion. Where the feet being forward and the knees in, maybe that's femoral anteversion. So not just looking at the foot position, but looking at the knee position. So when we're looking at a rotational profile, step one, which we just talked about, is the foot progression angle, assessing gait. And then the next really thing that can help you elaborate femur, tibia, foot is a prone examination. So the supine lets the hips have full range of motion. When you put them prone and bend their knees up to 90, it kind of locks the hip rotation in. And you can put your hand on the back of their butt to try and stabilize their pelvis. This is, I think, not intuitive, but the legs going out is actually femoral internal rotation. So, and the way that makes sense, besides the anatomy, is that kids who have a lot of internal rotation like to W sit, and that's kind of the same position, the feet out. So feet out is how much femoral internal rotation is. Feet in is how much external rotation there is. So B and C in that picture up there. And then you can kind of assess what their femoral version is. Kids who are in-toeing will often have lots of femoral anteversion. All normal little kids will have lots of femoral anteversion. And so kind of the anatomic picture of that is what is femoral version. This is, I think, maybe a little bit hard to visualize, but so our femur is a long shaft, and then there's a neck, and then there's the head of the femur. So it is what orientation that neck is in relationship to the shaft. If it's pointing really forward, it's anteverted. If it's pointing really back, so forward meaning like towards the tummy, back meaning towards the butt, it's retroverted. And the hip rotation is basically just determined by how the top of the femoral head likes to sit in the acetabulum. So it likes to be very well covered. So if it's facing forward a little bit, that means you're going to have a lot of internal rotation. If it's facing back a little bit, you're going to have a lot of external rotation. This is a little bit of this is a diagram that kind of tries to show you that. It is, I think this is a relatively difficult concept, even for some orthopedic surgeons, to be honest. So, but I think just the concept that it's a rotation within the shaft of the femur. And then the second concept is that it starts out as being anteverted with lots of internal rotation. So that kind of W sitting position you can see on the top right when they're prone. And then this is a graph of how it remodels as they age. So we expect it to be very high when they're young. We expect it to get better as they approach the age of 10, and then there probably won't be very much remodeling. When we think about when we see femoral anteversion as a cause of in-toeing, it's usually the older school age kids. It should be symmetric. So it's a normal physiologic thing. So both sides should be having it. The parents will often say that they trip and fall more than average because their feet are hitting each other. They sometimes run funny, like that kind of like scissoring egg beater kick. And they like to W sit, and school teachers, and just even my son's kindergartner, I hear it at home now. They say like, don't W sit, like you have to sit crisscross applesauce. And it's not that there's something bad about sitting that way. It's just that it's more comfortable for them to sit that way because that's where the hip is sitting more in a more comfortable position where it's in the socket. These are the Forrest Gump braces. So we used to put these on all kids, right? And it was pretty amazing. They all got better, but they all would have gotten better even if they didn't have the braces. So we don't think that there's any role for bracing, special shoes, special inserts, doesn't really make a difference. This is just a function of correction of time and longitudinal growth as they grow. The femur, that anatomy I was trying to demonstrate to you, will derotate. And as it derotates, they will have their rotational profile of their femurs will change and they will not have as much internal rotation. The only way at this point in time for us to correct this is to cut the bone. So a big surgery where we do an osteotomy, change the rotation and fix it. So once we see that, usually the parents are like, yeah, it's okay. So we almost never do that procedure as I just described. We don't recommend physical therapy. We don't recommend bracing or shoe inserts. And kind of the take home for this is that you will almost never miss the boat in this. It's not amenable to guided growth techniques, I should say as of yet, because there's some stuff in development. But even with some of that stuff, we wouldn't operate until they were older. So this is definitely something you can observe. Moving down the leg. So then, yes, of course. Yes. Yes. Okay. Yes. So they like to do it so it's comfortable. I think there are extreme examples where there are people who do lots of external rotation exercises. So like ballerinas, catchers, hockey goalies, where they're out all the time in that wide squat position. And I think some of that, lots of activity like that will help it remodel. Going to a toddler ballet class is not going to make a difference. So they should just do whatever is comfortable to them. Yeah, great question. Thank you for asking that. Okay, so moving down the leg, so tibial torsion. So the tibia is the next bone that we kind of consider how is this influencing the overall rotational profile. The best way to assess this is again in the prone position. Hopefully this projects okay. When you are looking, you're looking down at the child's foot when the knee is flexed, and we're simply looking at how the foot is positioned right in relation to the thigh. So thigh, foot angle, kind of makes sense. It's also denotated the same way. So plus is out, minus is in, 0 is straight ahead. You have to be a little bit careful in some older kids who have very flat foot. Some of the external rotation can be coming from within the foot and not necessarily within the tibia. So sometimes just cranking down on the foot is not as helpful if they have this midfoot break, but in younger kids, that's pretty rare to see something like that. And a good way to diagnose both internal and external rotation. So this is, we are also intrauterine molded to be internally rotated from our tibia. It's usually symmetric. It can also cause tripping and falling. And it's a good kind of picture of that line is, so just for example, I would say this child's thigh foot angle is minus 30 bilaterally. Kind of how we use that measurement. And it may be in combination, right? So these little kids will likely have femoral anaversion and tibial torsion, right? Because the femoral anaversion remodels last. We usually think that tibial torsion is done remodeling by the age of 4 or 5. But so the tibial torsion will get better. The femoral version will still exist. And so there's a lot of watchful waiting and reassuring parents with these diagnoses. We almost never operate on tibial torsion in healthy kids. We do sometimes do it in kids who have other pathologic issues like cerebral palsy or spina bifida. Physical therapy, bracing shoe inserts are not going to change the rotation. Again, the treatment is this big kind of procedure. We cut the bone and change the bone. And as soon as you kind of bring that up, it's like, okay, we'll just watch it. It's just a big surgery with a big recovery. And we don't really actually think it changes much in terms of flexion. So we very rarely do that. And then the last part of the rotational profile is looking at the foot. And this is metatarsus adductus. Again, really helpful to do this in the prone position. You do it at the same time as you do your thigh foot angle. So you're just looking at it. The measurement that we use for metatarsus adductus is a heel bisector line. So in a normal non-metatarsus foot, that should fall between the second and third toe. So you can see in this example, it's between about the fourth toe. So that's abnormal. And then we talk about whether or not it's, it's flexible or not. And one of the differential diagnoses for metatarsus adductus is clubfoot, and the big differentiation between the two is that there's no equinus contracture, so you can get the foot to come all the way dorsiflex back up. So if you're concerned about a curvature of foot that may be clubfoot, if they have good dorsiflexion, it's more likely just to be metatarsus adductus. Clubfoot is almost always associated with equinus contracture. Again, secondary to interuterine molding. And the way that we treat or don't treat this is based on flexibility. So if it's flexible, we encourage stretching exercises. Just an example of it being flexible or not, you can't push it. So you're just kind of pushing on the first toe to see if it will go laterally so you can correct that heel bisector line. And then kind of just like a summary that often reassures parents when we're talking about in-toers is that a lot of in-toers are athletes. So when they watch baseball and they watch people running the bases, or they watch basketball or something, there's a lot of toes pointing inwards. And so there's some reassurance that, these kids are going to be okay athletes. There is the opposite thing, right? So we spend lots of time talking about in-toeing because that really is kind of the norm and a lot of what we see, but there is obviously the rotation can go the other way. So external rotation or out-toeing. In little kids, that can be caused by hip external rotation contracture, so soft tissue. And then you can kind of go down the list in terms of the segments of the leg, where you can see the opposite deformities. So external femoral torsion or femoral retroversion, external tibial torsion, or the foot is going out, pes plano valgus or flat foot. Hip external rotation is often from soft tissue. And it is interesting because it can be severe enough that it hides the femoral anteversion that's almost there. External tibial torsion, again, this is, once you know how to do the exam for one, you know how to do the exam for all of these, right? So it's external rotation of the feet relative to the thighs. This is, in contrast to tibial internal torsion and even femoral anteversion, the kids that go out tend to be inefficient when they walk. If you try, some of you may out-toe, but if you try and you don't out-toe, walking with your feet out, it's not a very efficient gait. So these are often the kids that come in that say that they have pain, they don't like to walk long distances, and they can't keep up with their peers, things like that. There is a syndrome that we call miserable malalignment, which is a combination of femoral anteversion and tibial external torsion. Because this kind of, as you can see from this picture, kind of twerks the knee a little bit, we often see these kids come in complaining of anterior knee pain, and they can have patellar stabilization issues with frequent patellar stability, subluxations or dislocations. We're able to look radiographically at the torsion of the bones. So either with a CT or an MRI, you can get rotational profiles where they do thin cuts just at the hip, knee, and ankle, and then we can kind of overlay them and decide what the torsion is. If we are considering a rotational correction, we will often get this just to confirm our findings and also help us assess how much we should derotate in the operating room. So this is one example of a patient who presented with miserable malalignment syndrome, and she underwent derotational osteotomies in her femur with a nail and in her tibia with a frame. In the spirit of keeping it open, does anyone have any questions about rotation before I move on to coronal plane issues? Okay, cool. Okay, so we're going to talk about bow legs and knock knees. Similar. We want to take a good history. We want to know how old the patient, because that helps us decide whether it's physiologic. Is this going to get better by itself? Is it just a natural history of growth? How long has it been present? Has there been progression? Was there any kind of trauma or illness associated before the development of it? And are they having functional problems, pain? Symmetry is often a sign that it is normal, although not always. And then we want to know about metabolic or dietary abnormalities, the normal growth in any family history. The coronal alignment is much more dependent on the static physical exam versus the dynamic physical exam. It may be different weight bearing and non-weight bearing, but it's not really, especially in kids, a dynamic issue. In adults, that is sometimes can be different. So normal alignment. So in general, when I think about alignment, I am thinking about a line that goes from the center of the hips through the knees, through the ankles. And so if that line falls in between the legs, that is continued genu varum or bow-legged. And if it's genu valgum, it's the opposite. That line would fall outside of the knees. If you have a hard time remembering that, what I remember from medical school is the G in valgum is like gum and it makes your knees stick together. That helps. The rule of thumb is basically if you can get a hand between the knees or the ankles when one or the other is touching, that's abnormal. And similar to our rotational profile, there's a normal angular development. So babies are born, they're very often bow-legged. A lot of parents do not recognize that until they start weight bearing. And then when they start weight bearing, they say, oh my gosh, the legs are so bowed. This is normal until about the age of 2. And then we swing the entire opposite direction and they become very knock-kneed into valgus. And then around the age of 7, they kind of develop their normal adult alignment. Normal adult alignment is obviously a little bit of a range, but slightly into valgus. So kind of just this is the line that I imagine in my head, but kind of overlaid in terms of x-rays and clinical examination. So little babies, especially when they start pulling to a stand, you're gonna see that they're bow-legged, then they kind of straighten out, then they go knocked, and then they straighten out again. So we often see this physiologic genu varum in patients who are early walkers. And the combination of that with the tibial torsion can often look very impressive. The common treatment for this is simply just observation because most of it is going to resolve by the age or before the age of 2 years. Varus is common. Any varus that you see in a patient, so any bow-legging that you see in a patient that's older than 2 is abnormal and should be sent our way. But in younger kiddos, it will often just resolve on its own. Again, patient with who is bow-legged, that tibial torsion is really a distractor and it doesn't look so bad when you kind of cover up the foot, so that can be helpful. There are lots of reasons why we see pathologic genu varum. Probably the most common one is Blount's disease in our overweight population, but you can also see it in from other etiologies. The x-rays that we get for Blount's disease are in infantile kids you can see this beaking medially. So that's something we use to see whether or not it's to try and distinguish between it being pathologic and physiologic. Blount's disease, as I was just showing in that x-ray, is a picture of the medial physis. We see it in little kids. They're more likely to be African-American, obese, and really early walkers. In the little kids who are infantile Blount's disease, it's usually bilateral. And they're normal at birth, and then it gets worse. And then in later onset, we see it more likely to be unilateral, but still obese. And again, just an x-ray to show that medial tibial physeal beaking is something that we're looking at to show that this is abnormal and it's not just going to remodel by itself. So in the bow legs that we're seeing over the age of 2, we're getting x-rays to see if it's bounced or not to try and understand whether or not it's going to resolve on its own. And then some people may do bracing. I don't know if Dr. Sabharwal does. Yeah. So early in my career, I used to do bracing. None of the kids like it. This is like a ridiculous brace for these little, to get on these little legs. They don't like it. They don't wear it. It's a lot of effort to try and get it. And I don't think it makes a very big difference. Similar to scoliosis, as they were talking about, where they talked about like measuring the time in the brace. Maybe it would have some impact if they were in a brace a lot, but I just don't think they're getting any time in the brace. And then newer techniques, again, as Dr. Diab had showed, is these guided growth to try and tether the healthy growth plate to try and let the unhealthy side of the growth plate catch up. And we're doing that as young as 3 or 4 years of age. And so, yeah, after 2, we would like to see them early because we can influence their growth and their lower extremity development. And then the opposite, genu valgum, so being knock-kneed, is typically normal in a child less than 7. Again, there's no role for bracing, and we usually just watch them. There are definitely instances where we see pathologic genu valgum. So if one thing that kind of sets us off to there being something abnormal, if the clinical appearance is different between the 2 sides, so it's worse unilaterally. The pictures aren't displaying. And then there's obviously systemic issues like skeletal dysplasias that can cause genu valgum. So this is multiple hereditary exostosis. We usually see genu valgum. So this is an example of guided growth to help correct genu valgum. Relatively simple surgery. These plates usually stay in somewhere between 1 and 2 years and then are removed after they're corrected. The patients are very happy with this procedure, in contrast to the osteotomy procedure, very small. So when should we see genu valgum? We should see it in kids. Healthy kids with mild knock knees should be referred depending on your conversation with parents. So the point here is that after the age of 7, that patients have reached their kind of end coronal plane alignment. So they're either going to be varus, valgus, or wherever they are, it's not going to change. If there's concerns about their alignment at that point and they still have growth remaining, there's a relatively small procedure that we can do. And so we'd like to see them before they finish growing, to have a discussion with the parents about the pros and cons of changing the alignment. There's relatively good evidence for kids who are bow-legged even just a little bit, that if they stay that way, that they may go on to early knee arthritis. And so we tend to be a little bit more aggressive in them. The kids who are knock-kneed, there's not as great evidence in terms of long-term arthritis picture, but cosmetically, patients are often not pleased with that. And so, it's a conversation about risks and benefits of how the legs look versus the risks of the procedure. And then anything that's you think is pathologic, that you could get more than a hand between the ankles if the knees are together, or if it's only one side, we'd love to see earlier rather than later. I apologize about the background on the slide.
I'm hoping we'll have time for questions at the end too. So maybe we'll sort of do the next couple of mini sessions, and then go from there. Yeah, please. All right, thank you. How are we doing on time? Yep. Let's go to the first one. Awesome. All right, great. So, Dr. DeBorja already introduced our panel. So I'm really proud to be in a community where we've got a lot of good talent with special skills, and we complement each other. So that's great. These are my disclosures. So starting with the name, right? And it's a struggle we have even now, because it's sort of like the hospital for crippled children. That's sort of what's been there for a long time for certain institutions, but everybody's trying to change that for obvious reasons. So we do say we specialize in limb deformity, but really what we mean is we specialize in limb differences, right? which could be physiologic, as you just heard from Dr. Hill, or could be non-physiologic / pathologic. So causes for limb differences, again, like you just heard, physiologic and pathologic. And just like any other thing we learned in med school or PA school or physical therapy, is you got to sort that out, right? Because so different in terms of evaluation, treatment, etc., guidance, prognosis. So, and just like any other pathology, it could be different etiologies, could be congenital, developmental, etc., etc. So we're not going to get into all the details, but again, just like you heard, know what the normal trend is. Oops, and this picture, there's some issues with the PowerPoint version, so some pictures may be messed up. But what this was trying to show is what Dr. Hill already showed, that remember that bow legs to knock knees to little knock knees from birth to age 4-ish, where it's maximally knock kneed, and then by 7, when it kind of plateaus to the adult version. So going on to treatment options, right? Basically, for limb differences, we have 4 things. And when I say limb differences, it's all planes, right? There are 3 dimensions. There's frontal, there's sagittal, and there's axial, meaning, varus valgus, internal external tibial torsion, or what's called procurvatum, recurvatum. And once you've sorted out, is it physiologic or not? If it's not, then your options are bracing, which has limited role in the non-neuromuscular population. And then the 2 that are surgical is guided growth and osteotomies. So very simply, people make fun orthopods or carpenters, and to some extent that's true. So, what's an acute correction is sort of like carpentry. You cut the bone, you fix it, you straighten it, the child or the adult wakes up, and the bone is where you want it to be. That's an osteotomy with acute correction, has its own pros and cons. Gradual correction, I guess, comes in 2 flavors. One is you cut the bone and you gradually straighten it out, what's called, fancy word, distraction osteogenesis, where you kind of fool the body into thinking it's broken, and it is broken, and then you wait for 5 to 10 days, called the latency period, and then you slowly pull apart the bone ends at a certain rate and rhythm, which causes bone to fill up in that gap. And then you wait for it to consolidate and you take that device out. So that's osteotomy with gradual correction. Or, like Dr. Hill said earlier, you could manipulate the growth plate in the growing years of the child. And that can be done temporarily or permanently, meaning you could put a plate without messing up the growth plate itself or the perichondrium, and then it'll just guide with a plate or a screw across the growth plate. And so there's differential growth at the ends of the bone, and we'll show examples of that. So this again is just a pictorial form of gradual lengthening with distraction osteogenesis. It can be done with external devices. It can be done with internal devices. It can also be done with hybrid techniques with internal and external. The biology doesn't change, the device and technology evolves. So here's an interesting patient, actually a young adult, that Alex and I saw, Alex Geraldi, our PA, and he remembers, and I think Brent probably remembers too, and actually Yumi does too probably, because this patient went through inpatient rehab at some point. So he came in with bow legs, and actually, like Dr. Hill showed, a patient with sort of squinting patella. You can see he's got a little bit of that squinting patella as well. Anyway, he had some knee pain medially, didn't like the way his knees looked, and we sort of offered him both techniques. You could get an acute correction or you could get a gradual. So I think first he said, let's go for gradual. So on the left side, we did a gradual correction and got his, mechanical axis restored to where we wanted it, very controlled gradually. And those tapes, if you're wondering, is at the end of the lengthening when it's consolidating. So you don't want those struts to kind of go on their own. So that's just a safeguard. And then he's like, I really didn't like that experience with a fixator, 4 months of this monster on my leg. Can you do something different? So he said, sure, we can do an acute correction. So on the other side, we did an acute correction with, distraction, straightening out the bow-leggedness in both planes, and then putting a little graft, as you can see on the bottom right. That's just a structural allograft, and then plates and screws. And he was, honestly, I was curious. This is a nice case control, right? Which experience did he like? And it's funny, at the end of it, he actually gave a very astute answer. He's like, the journey was better with the acute correction, but I like my left leg better the way it is. And I think, it's funny because I think what we could do with the left side is we could also correct some of his rotation, which sometimes you can and cannot do. But I'm not saying one is better than the other. I'm just saying these are two options, and this was one case where he had both. Then, going on to other sort of ways of doing it, which is physeal manipulation. And it's nice to be familiar with these different terms, some of which are overlapping and interchangeable. Hemiepiphysiodesis means doing something for an angular deformity in a growing child, where you put a device on the convex side of the bone so that the concave can grow and the bone realigns, right? That makes sense? And you could do that with implants, either, these plates with screws on either side of the growth plate, or in the old days, the middle picture shows you a staple, which we don't use anymore for the most part, or some screws, which you could see at the bottom right, which you can use for, both coronal and sagittal deformities. And the point is you put the implant on the convexity and let the concavity grow, whichever way. And the central two pictures are actually a nice one from my prior practice, where this kid had an aneurysmal bone cyst and had 3 prior surgeries and really not a good outcome. And all we did was a same-day procedure with guided growth and let nature take its course. And over the next year, his knee straightened out and he was happy. So sometimes these lesser invasive procedures actually are more effective and less morbid. Okay, I'm going to switch gears now. And while it's slightly an esoteric topic on congenital shortening, I think it's a nice way to sort of showcase what's involved in a practice with limb differences, and hopefully we can get our panelists to chime in. So I'll start with, and I'll kind of pick on all of you, 4 of you, to sort of showcase some cases. So this is a 9-year-old, and these are all cases in my practice here in California in the last 5.5 years. Actually, maybe one not. 9-year-old with a 10 centimeter leg length difference, congenitally short femur, and not to go into all the details, but maybe with Dr. Hill, Jackie, what are the associated abnormalities that people should watch out for in a child with congenitally short femur? And these are a few of them.
So definitely we want to check what the joints are like. So it's not just the length of the bone that's short, but the hip and knee may not develop correctly. So before we can consider, especially a lengthening, we want to make sure that the joints above and below are stable, or at least we understand what the potential issues might be if we start to try and lengthen, because we want to leave them with a longer, better leg, not a longer leg with bad joint above or below. And then the other consideration is that it's often not just that one bone. So the tibia bone may be affected, most likely with fibular hemimelia. It's usually not a tibial hemimelia that is associated. So trying to understand, is the leg length difference just coming from the femur, or is it also coming from the tibia and the foot? So thinking about segment differences, and one of the things that I spend a lot of time thinking about, maybe too much, is when I'm done with that leg, are the knee heights going to be in the same range of each other? So we think a couple centimeters is okay, but making, if there's a 5 centimeter difference from the tibia and a 5 centimeter difference from the femur, probably not okay just to lengthen the femur, because the knee height's going to be very different. The pelvis may be level, but that's probably not biomechanically okay. And when we choose, which we sometimes do to get the length from all one bone, especially the femur, because it's the easier bone to lengthen, making sure that the family and patient, because oftentimes these are teenagers as we approach the final stage of lengthening, understands that their knee heights may not be equal. So that means that when they sit, one femur may still look longer than the other. And when they're standing, if they have shorts on, it looks different, because I think that the patients notice that. And they're like, well, my legs are still different, right? It's like, so understanding the overall goal of getting the pelvis within a certain amount. So we're avoiding issues later, but that we have to focus our treatment on certain things based on the pros and cons of different surgeries.
Yeah. No, that's good. Yeah, perfect. Thank you. And I think, that's what's unique a little bit with the limb difference population, that we got to make a game plan, a lifelong plan, day one. And so we need a little bit of predictions in terms of what this child will need, what, if any, lengthening he or she will need, etc. And like Dr. Hill said, you can always make the bone longer, but you can't always restore joint function. So, it's always about joint function, and that's where, physical therapy, having joint preservation surgery, not being too greedy with limb lengthening are really, are good safeguards. Another thing that parents are very interested in is, let's say they have a child that was newborn and one leg is shorter than the other. And so mathematically, they want to know, well, okay, it's 3 inches short now. What's it going to be like when the child's done growing? So thankfully, it's pretty simple for congenital shortening. And this goes at any age, meaning the growth inhibition in the short leg is linear. So if it's 20% shorter than the long leg, that 20% differential is going to stay for the rest of their growing lives. But of course, the amount in centimeters or inches is going to get longer. And so there are these different formulae you can use. You have a software, you could plug in the numbers. So the point is, it's very easy to give the family a guesstimate of what the LLD or leg length discrepancy is going to be at maturity, and then plan treatment accordingly and let them decide. And sometimes, the decision is not between lengthening when, but it's lengthening versus, prosthetic reconstruction. So I think those are, good things to think of. And then, back to associated issues and preparation. So there's a lot of preparation that goes into, let's say, a congenital shortened limb prior to actually doing the lengthening. Like you just heard, there could be hip dysplasia with it, which is not uncommon. You want to over-cover the hip joint so that as you're lengthening the femur, the hip doesn't sublux or dislocate. That can happen. And that's where therapy comes in too. And so you need a reliable, and we're lucky to have, very good therapists at all locations. And they understand, and we have protocols to say, okay, if you're going to get a femur lengthening, you want to make sure the femur or the hip is abducted, which seats the ball better in the socket. And a lot of these patients have ACL, PCL deficiency. And as Brent's going to tell you later, you want to sort of manage that by positioning the knee in a certain way. And you can mix and match things. So if you're making a plan of what this patient needs long-term for limb length equalization, so this patient at the same sitting, his left leg was probably shorter. So we did femoral supraacetabular pelvic osteotomy to improve the hip coverage. And at the same time did a drill epiphysiodesis, which is a permanent epiphysiodesis of his long leg distal femur, so that he doesn't have to undergo multiple sessions of limb lengthening. And then, so this is an older patient from my prior practice, but just to show how we've evolved in technology, let's say even in my practice in the last 10 years. And this was the time I was kind of doing both external and internal lengthening for femoral deficiencies or differences. But this is sort of the classic external fixator frame. And what it has is you've done an osteotomy in the distal femur for lengthening purposes. But then, and I hope this video plays. Yeah, and then you put these hinges across the knee joint in order to stabilize the knee. so that it maintains motion, but at nighttime, and you can see on the bottom right, the patient sleeps with the knee extended so they don't get a flexion contracture and get knee subluxation during the lengthening course. Okay. So I'm gonna stop here for a little bit and let Brent and Yumi and Alex chime in. And maybe, Brent should go first in terms of physical therapy, and then perhaps Yumi for inpatient, outpatient rehab consideration, and then Alex for, post-op care.
So to Dr. Sabharwal's point, maintaining motion and joint integrity is really one of the most important things that we do in physical therapy after surgery. So looking at these pictures, if you look at that bottom right, you can see that it's indicating that there's this risk for the tibia to slide posteriorly, especially in cases where you may have a PCL deficient patient. Similarly, if you have someone who's ACL deficient, if you look at them and they have that knee flexion contracture where they're not able to get to full knee extension when they're ambulating later on or things like that, that knee is going to be at a greater risk for getting some of that internal rotation, subluxing both either anteriorly or posteriorly. So after surgery, the big things that we're looking for in a femoral lengthening situation is we want to maintain full knee extension. And initially our first goal is to get 90 degrees of knee flexion. We especially want to get that knee extension, like I said, to maintain the integrity of that knee joint, reduce risk of subluxation. And then that 90 degrees really is, you can imagine, if we're lengthening the femur, you're putting a sustained stretch on that quad. So the quad tends to get very tight. Patients don't really want to bend their knee. And so part of the other really important thing that we do is creating and maintaining expectations with both the patient and the family in terms of, hey, this is what you're going to experience. This is what we're trying to do and why. I need you to be stretching X times a day, 20 minutes at a time, 30 minutes at a time, regularly, and really helping them understand that this is what we need and why. It makes the process a lot easier. And just for a show of hands, how many physical therapists are here? Awesome, thanks for coming. We all know that you get better buy-in from patients when it's not just someone is telling me what to do and I don't really know why, but I was just told I was supposed to do this. So a huge part of what we do is creating the plan and expectations with the patient so that they understand. Similarly, if you're doing a tibial lengthening, in the same process that quad can become really tight, the calf tends to become really tight. So we're really trying to maintain that ankle at least at 0 degrees of dorsiflexion, if not more. The majority of the time, actually, all of the time, they're gonna get something that will attach to their talar spatial frame if they have that, something to hold the foot in neutral dorsiflexion. But again, really understanding that, hey, we need to maintain that range of motion. So not only to help maintain the integrity of the ankle, but also if that calf gets really tight, it's gonna, again, wanna pull that knee into a little bit of flexion and put the knee at risk. And then also when they start to ambulate afterwards, they're gonna have a lot easier time if their foot hasn't been stuck in 20 degrees of plantar flexion and now they're trying to put their foot on the ground. That also has some implications for preoperative care, which is if you have a kid who has a congenital leg length discrepancy, maybe they haven't put their foot really on the ground their whole life and their foot is always sat in plantar flexion. And so we're talking about, hey, before surgery, you're gonna have a lot better time if you start doing some calf stretching now before you're dealing with all the other mess of the frame and all the stress and anxiety that comes along with that. Start working on this now. It can make things a lot easier for you after. So again, post-operatively, hopefully we've already had the chance, and I know the rest of the team has had a chance to talk to them about expectations, things like that. But then again, they're coming into physical therapy, they're looking for reinforcement of that, reassurance, and here's the other thing, we see them at least 2 times a week most of the time. So we are getting really close to these patients and families. You're trying to develop a trust that, hey, this is my first time going through this, but my therapy team, they've been through this a lot before, and they're here to help me and give me the proper guidance that I need.
Great. Yumi, you want to go next?
Sure, yeah. So my specialty is physical medicine and rehab, and when in this patient population, our role is pretty minimal, I would say, because it's really the surgeons who are fixing the limb differences, and then the physical therapists who are doing the hard work of, getting these patients back up and mobile and functional. But just to kind of explain what or maybe give you an idea of what the patient experience is when they come to our limb difference clinic. So it's a clinic we now hold every other month, once a month, and it consists of orthopedic surgeons, PM&R specialists, PT, and prosthetist orthotists, as well as a nurse coordinator and a social worker. And most of these patients have already been seen by Dr. Sabharwal or Dr. Hill in ortho clinic, and already have a surgical plan in place. And they come ahead of the surgery to kind of develop their overall treatment plan, including the rehabilitation. So we examine the patient together as a team. And we're getting all of the social history as well, trying to identify barriers to really going through this rigorous physical therapy program afterwards. And our social worker helps to address those barriers. Most of the kids who are in this clinic don't have any associated kind of central nervous system disorders, so they don't have any like abnormal tone that we would need to address, but they do have range of motion differences, and like Brent mentioned, if they have been not weight bearing on the one side, they're going to have weakness on that side. So those are all of the things that we want to address in physical therapy pre-op to strengthen the muscles that need strengthening to help with the recovery process. And then part of what we help with in the pre-op phase is to decide whether, okay, after this patient has the surgery, is it appropriate for them to do a short course of intensive rehabilitation in our acute rehab unit versus moving straight onto outpatient therapy? Of course, all of these patients after surgery will be seen by our acute PTs and OTs post-surgically. But the patients who are typically admitted to inpatient rehab for about a week to 10 days afterwards are those who are going to have the external fixator placed, because it's a big, bulky, heavy thing that they are now going to have to move around for weeks to months. And it's also scary too, right? When so many pins in, and parents are really hesitant to really kind of even go near it initially. So the Alex and his team are going to be training the family on the pin site cleaning and the strut adjustments. And it's just, they feel more reassured when there's, they're in the hospital, and if there's some concerns, then it can be addressed right away. And then our acute OTs and PTs also make a foot plate from like an aquaplast foot plate, just to help for people who have the tibial lengthening external fixator. Like Brent mentioned, their foot naturally gets stuck in that plantar flexed position. So just immediately post-op, the OTs will make the foot plate to maintain the ankle at neutral. And then they get 3 hours of therapy between PT and OT per day, mostly PT, but OTs also help with kind of helping the kids navigate, okay, at home, how are you going to be showering, or how are you going to be transferring in and out of your wheelchair or to the toilet? So all of the things we troubleshoot during the inpatient rehab course, so that by the time they go home, they feel confident, or more confident at least. And then they will move on to the outpatient rehab phase, and it's very kind of streamlined because our inpatient therapist will have communication direct communication with the outpatient therapist. And in California, some of these kids are clients of the CCS medical therapy program, or California Children's Services medical therapy program. And so they already have their designated PT/OT team out in the community. So our inpatient therapist will also directly kind of sign out or discuss the protocols to be continued at the CCS units. However, we typically, for the acute kind of several weeks after the surgery, we do tend to like to have the patients follow with our physical therapist, outpatient physical therapist, just because they're more familiar with the whole process.
Great, thank you. Alex, you want to say a couple of words about pre-op, post-op?
Yeah. So preoperatively, we see these kids very similar to what you mentioned in this pre-op clinic, where we have the full interdisciplinary team together. And then Dr. Sabharwal and myself see them all individually. And I think the biggest thing that we can kind of get across to these kids and families is it truly is a fully encompassing team. Not only us as providers, the PTs, everyone else, but the family really has to buy in and the patient has to buy in. So taking that time preoperatively to explain everything and giving them that time to understand what they're going to be going through for 3 to 4 months is really, really important. And then kind of fast forwarding, obviously surgery itself is intensive, but the post-operative care is just as intensive. Kind of picking up from where Yumi left off from the post-op plan. Once they get out of the acute inpatient rehab, Dr. Sabharwal and myself see them pretty frequently, to the point of where it's pretty much every week. And during that time, we're making sure that these kids remain on schedule from both their lengthening as well as from a clinical standpoint, as well as mentally. So again, having some sort of large external frame on them is tough for them, whether they're staying home and not being able to go outside because they're upset about it, kind of how everything looks, or just from the standpoint of making sure they mentally are game and ready to continue with this entire process. So with those weekly appointments, we kind of check in with them from that standpoint, but then also checking x-rays to make sure that these kids are remaining on schedule, their strut turns, and making sure that their x-rays continue to show distraction across that area that we previously cut. Like Yumi mentioned, there's daily pin site care that we have these families do. It's very, very important to keep that area kind of as clean as possible. It is common to get these very minor pin site infections. We combat that not only with daily cleaning, but also just some small antibiotics for like a week course. And then from there, as these kids continue to get farther out, when we see them weekly, we kind of progress through that lengthening phase. We get to this consolidation phase where the bone is filling in more. These kids are now 2-ish months in, assuming we've kind of got the correction that we need, and they can start advancing a little bit more with Brent and his team, advancing their weight-bearing status. And during that time, we're just making sure that not only their x-rays look good, but clinically, again, like Brent mentioned, their foot is plantar-grade. They can maintain knee extension, knee flexion, and they're progressing from an x-ray and clinical standpoint. And then we get to the point about Indicare, like Sabharwal mentioned, 4-ish months where the bone is consolidated fully, and they're now ready to have this external device taken off. And that's a relatively quick same-day procedure where we take off this frame and they advance, not only again trying to get their knee flexion, knee extension back, but then walking without this large frame on their legs. So it really truly is an intensive process that requires all of our team.
Yep, thank you. That's great. So, I mean, you just get a flavor, and I know some of you are not going to see a lot of these patients, but honestly, I think it's been a good exercise for me too, in terms of trying to get all the players together and kind of have a team building. And also and I'll move forward, just to sort of show you the evolution. So don't think every patient needs a fixator. So now, thankfully, with technology, while the biology hasn't changed, the technology has evolved. So it's more user-friendly, using more sort of internal lengthening devices, especially for the femur. So I'm just going to showcase a couple of cases and then we can open up for discussion, maybe 2 or 3. So just on that same theme, same topic, congenitally short femur. So you saw what I did a decade plus ago, which was all external, protect the joint, etc. Now this is a slightly more recent patient, similar issue, 11-year-old, 7 centimeter congenitally short femur, had preparatory surgery. And of course, this is a sports conference, so I can't help but tell you that these patients a lot of them have ACL, PCL deficiency. So Dr. Pandya and his team, like for this patient, did extra-articular ACL reconstruction. Again, to stabilize the joint, because you're going to put a lot of force across the knee joint as the femur's lengthening. So under the same anesthetic, while he did the ACL, I put in a little guided growth in the distal femur for his mild genu valgum, and he had a ball and socket ankle with some valgus. So we put in a screw in his medial malleolus so that over time that ankle doesn't go into more valgus and corrects itself. So, again, this goes back to team approach, using all players that you need to get the patient back to recovery. Once it's all done, then we went ahead and did an internal lengthening with this magnetic intramedullary nail. I'm not going to talk about proprietary names. Really, this is one of 2 devices that's FDA approved at this time. And it's a magnet. There's no external pins. Yes, go ahead, sir.
Sorry.
No, go.
Previous slide, where you say extra-articular ACL fusion?
Yeah. So what that means is the femoral tunnel is intraepiphyseal. So it's not totally extra-osseous. And again, I didn't do it. It's Dr. Pandya's work. But the tibial tunnel is central in there. So depending on the age, we typically don't do ACL reconstruction in this population before age 10. And a lot of times we stay away from the classic, bone tunnel, femur, tibia. So the real young ones will have a totally extra-osseous ligament reconstruction, let's say with the fascia lata plus minus an allograft. And as they get older, and depending on what you're trying to correct, you can do a tibial tunnel in the center, but in the femur, you try to do a physeal sparing reconstruction. So you can either go, typically like in this case, you can see there's that endo button or the button that's in the epiphysis. So most likely he didn't go through the growth plate of the distal femur in order to prevent any growth disruption. Yeah, make sense? Yeah, good, thank you. Okay, so that was the lengthening, and then and again back to this theme, not to be too greedy with the length. Typically, we don't go more than 5 centimeters in one session of lengthening gradually. And another way to think of it, we try not to go more than 10-15% of the original bone length, just because the soft tissues, the nerves, the joints can't always handle it. Now, we do push the limit sometimes, but again, with good therapy, good inpatient rehab, regular follow-ups, we can do that. But even before we start embarking on the journey, we tell them our goal may be, let's say 5, but that doesn't mean it's a guarantee. If he or she's losing motion a lot or they're non-compliant with physical therapy, then, all deals are off. Because, we can always lengthen again, we can't preserve motion. Okay, so this was his early follow-up, and then the implants came out, which is, part of the deal. The guided growth implants came out too. And, we're going to do a second lengthening closer to skeletal maturity with an internal device, and he'll be done. So, 2 sessions of lengthening at different ages during his growing years, then he's done. I'm just going to move on to how we're sort of now pushing that envelope with younger kids and doing, more creative ways of lengthening without external devices. So much younger kid, 5-year-old with a congenitally short femur, 5.5 centimeters of leg length discrepancy at maturity, just did the guided growth stuff to kind of tune up her alignment, and then came back, and here's her shoe lift. And I don't know if we didn't have time to talk about shoe lifts yet, but we can, if that's a question in your mind. But here we did an extramedullary internal lengthening, meaning you've put this lengthening magnetic nail, but not outside the skin, but under the skin. Oh, why is it not moving? Oh, that's interesting. Needs a tip. Weird. Thank you. All right. Something weird. Maybe my time's up. Okay, so extramedullary internal lengthening. So same kind of thing, but you're not putting external fixator pins. You're kind of using that lengthening nail, and you still have to kind of guide the bone. So you put a more flimsy intramedullary device just so that, the bone doesn't go crazy. But then, what do? You don't have the external fixator luxury to go across the hinges, to go across the knee with hinges. So then you got to do something. So you can use a hip HKAFO, hip knee ankle foot orthosis, and to keep it in a safe position. And what's a safe position for the hip is abduction, avoid flexion. So abduction, extension of the hip, and knee extension and ankle dorsiflexion. So those are kind of the safe functional positions for the, but this is the game changer that, and I'm not like cooking slides here, but 4 weeks after finishing lengthening, we wouldn't see this in the old days with external fixator lengthening. This kid truly recovered, all her knee motion within 4 weeks of the consolidation, of the end of distraction rather. Okay, and just pushing it even further, 7-year-old with a much larger discrepancy. He was actually treated in Southern California with preparatory surgery for his hip, and they did a great job. And here he is walking in the office, and that's his x-rays with when we took the implant out in preparation for his lengthening. You could see he's got an ACL, PCL deficiency. His predicted leg-length discrepancy at maturity was a lot, 17 centimeters. But thankfully, he has a very functional foot and ankle. So prosthetic reconstruction in these patients is probably not the prime indication, although, it can be offered as an option. But with such a functional foot, I think in this day and age, we could go to leg-length equalization in installments with a relatively safe, predictable outcome. So his first lengthening, and this gets into the technology of, the lengthening nails are there, but they don't come in all sizes and shapes, etc. So here again, maintaining those same principles, and again, doing limited lengthening. I think this kid just had like a 4-ish centimeter of length, and, safely maintained his knee motion. Again, still has a big shoe lift, but it's, first of perhaps 3 to 4 lengthening sessions, plus minus a contralateral epiphysiodesis. So I'm just going to finish with this one. This is from my prior practice, but just to kind of show that there's many ways, and sometimes it's not so clear. So 8-year-old boy migrated from another country, still doesn't speak English well, adjusting socially, has a very, very severe congenitally short femur, and has a functional foot. So what do you do in this case? Sorry. Okay, I think this video is messed up, but let's see if it plays. And that's the creativity in kids. Even with a single leg, they can walk 3 different ways equally well. He can walk with his knee bent, he can hop, and he can walk with this prosthesis, which is a prosthesis with a big, with a brace, but not forever, right? I mean, we all get stiff, literally. Okay. So just to sort of show, and I'm sorry, these slides are a little bit, the picture didn't show, but this kid had a very functional, lengthenable extremity, but socially, the family wasn't ready for all the rehab, all the physical therapy. It was one of 8 kids with limited means, and she was like, I want one and done. So we did ankle disarticulation, a sign amputation around age 1 year, was fitted with a prosthesis soon after. And I mean, that's the other principle, right? even when you're doing a prosthetic reconstruction, you should follow certain goals in terms of age-appropriate reconstruction. So kids start walking around age 1. That's kind of when you do the amputation reconstruction, so that then they're ready to walk just like they normally would, and they adapt well. So I had the fortune to follow this kid to skeletal maturity in my prior practice, and she did great. She needed a couple of guided growths for her femur, but had a very, I would say, at least in my opinion, a very normal childhood with limited number of visits to the medical facility. So I think the lesson here is, don't make decisions based on imaging alone. We obviously have to look at the whole picture. So I think I'll end with that. And just a plug for our webinar, we sort of do this once a year. This is our 3rd annual webinar, and it's, again, a multidisciplinary thing. And the other part that we're interested is limb differences on a global level. So if any of you are interested in sort of global outreach, etc., please join us for this webinar. Thank you. We still have 12 minutes, right? So we can open up for questions, if any.
All right, thank you very much to our multidisciplinary team at the Lower Limb program. Any questions from the audience? Question from the back.
Is there an age limit for how late? Got a new patient to me who's 22 with a significant limb length discrepancy.
Jackie, you want to go?
So, the principles for limb lengthening are the same in pediatrics as they are in as adults, so we're happy to see that. Thank you.
Yeah. But you're right. I mean, so there are adaptive changes. There are adaptive changes. And, then you have to wonder, why did he or she not get treated before? So, I'm sorry, Nicola. Yeah. So I think if the social situation is sorted out, I think, of course, kids are not young adults and adults are not always young kids. But I think if you've got the right setup and, realistic expectations, then it's absolutely doable. But obviously it's case by case. What's the magnitude of discrepancy? What's their expectations? And what we didn't talk about is another thing. We just talked limb lengthening, but there's limb shortening. Femoral shortening is a very time-tested procedure of up to 5 centimeters. So somebody doesn't want to go through limb lengthening. We could take a segment of bone out from their femur up to 5 centimeters acutely, and then they're done. Any other questions? All right. Yes, please.
Hi, are there best practices for primary care providers to measure these leg length discrepancies?
Sure. So leg length discrepancy measurement, it can be clinical and radiographic, right? So clinically, there are 2 or 3 ways of doing it. One, the easiest is, supine on the table, and there are 2 variations on that. People talk about true leg length and apparent leg length. True leg length, all you need is a long tape measure, right? So you go from the ASIS, anterior superior iliac spine, down. I don't use the medial malleolus. I actually go to the bottom of the foot, because there could be a foot height difference. So you go from the ASIS to the plantar aspect of the foot, right side, left side, and see the difference, right? Then you can also, because sometimes, kids, ticklish or doesn't sort of stay still. There are 2 other ways of doing it. One is to put the tape measure on the umbilicus, I guess. Make sure that the torso is square with the lower extremity, and then you could just do, leave the thumb at the umbilicus and then just go foot, look at that. The caveat there is if somebody's got an abduction contracture or a flexion contracture, that can throw you off. The classic one is have the patient stand on known amount of a height, like a wooden block, 1 inch, 2 inch, 3 centimeters, those kind, and then feel the pelvis from the back or the front to sort of see if it's level. those are sort of the clinical. Radiographically, our classic is we do what's called a bone length X-ray, where a patient is standing with an X centimeter lift underneath the short leg, and then we can measure, just like Dr. Hill said, the mechanical axis, hip to ankle, look at that, see where it's coming from. So that's our preferred thing, but we always do both. We do clinical, supine, standing, and then the X-ray. Yeah. Anything else to add? Final words? All right, good. Well, thank you.
All right, thank you. And so that concludes our morning sessions. We have carved out a few minutes for some networking and gatherings. So please don't hesitate to reach out to any speakers or course members that you encounter. During this break, we'll have lunch until 1 o'clock, which should be a good hour and a half for eating and mingling.